Good morning, everyone. Dr. Friedlander is on vacation with spotty internet, so I'll be pleased to introduce the series and our last speaker of the Fralin Biomedical Research Institute Pioneers in Biomedical Research Seminar Series. This seminar is co-sponsored by the Addiction Recovery Research Center and the Center for Health Behavior Research. At the end of as the talk is going on, if you have questions, please put it in the chat and I will bring them to the attention of our speaker. Our speaker today is Dr. Lisa Marsch, a world-class investigator in the development and testing of digital therapeutics. I am particularly pleased to introduce Lisa because I had the great fortune of being her advisor when she was in graduate school, some 25 years ago. She was a wonderkin then, shown by how much she did, how well she did it, and the impact she generated. This pattern of behavior has led to the important role she now plays in national and international digital therapeutics. She is also simply among the most positive and upbeat individuals you ever have the chance to meet. Lisa is currently the director of the Center for Technology and Health Behavior, the director of the Northeast Node of the National Drug Abuse Treatment Clinical Trials Network, and the Andrew G. Wallace Professor within the Geisel School of Medicine at Dartmouth College. The Center for Technology and Behavioral Health is an interdisciplinary center of excellence supported by the U.S. National Institute on Drug Abuse. Lisa shared that the center has been renewed for years 10 through 15, which is an exciting development and should be able to continue this work that uses science to inform the development, evaluation, and sustainable implementation of digital therapeutics in the treatment of persons with substance use disorders, mental health disorders, and other behavioral health challenges. These tools are designed to deliver engaging, effective, and widely accessible health monitoring and health behavior interventions to collectively lead to transformations in the delivery of science-based behavioral health care. Dr. Marsch is a regular keynote speaker on digital therapeutics at national and international meetings, including invited presentations at the White House, congressional briefings, the World Bank, and for the U.S. Surgeon General. It's my pleasure to ask her to give her talk, The Application of Digital Health to Behavioral Health, State of the Science and Vision for the Future. Lisa?
Great. Well, thank you so much. It's such a pleasure to be here with all of you today. I've just enjoyed so much my meetings with a number of you and look forward to more meetings today. And it's just been terrific to hear about the very excellent and pioneering work at your institute. And thank you so much for the opportunity to come here today and share with you about some of the work our group has been doing. And I'm especially grateful to Warren for that beautiful introduction. Thank you so much for that. It was such a wonderful opportunity in my life and career path to have the opportunity to be Warren's graduate student, and really shaped that formative training, really shaped my path since then. So I will always be grateful for that. So as you have heard, I'm going to talk about digital health today. And in addition to my academic affiliation at Dartmouth College, I have an affiliation with a number of small businesses that are involved in developing and deploying different digital health tools. I'll tell you a bit more about our research center later, but our center has increasingly been expanding our academic industry partnerships. I want to acknowledge the funding for the work I'll be highlighting today, in particular, our center grant from the National Institute on Drug Abuse, as well as a number of research grants from the National Institute on Drug Abuse and the National Institute of Mental Health. So digital health is a term that refers to using digital technology like mobile devices, for example, to measure individuals' health behavior. So it's digital health assessment of health behavior, but also it encompasses using digital technology to provide digital interventions, which are called digital therapeutics, that can provide treatments to individuals anytime and anywhere. And so this is what I'm going to be covering in the talk today, is the spectrum of digital health assessment, digital therapeutics, and how they intersect. So first, just to underscore the ubiquity of technology, as you likely know, access to the internet, access to mobile technologies has been growing exponentially all over the world. The majority of the world has access to mobile devices. It's about 8 billion mobile phone subscriptions worldwide. And the rate of access continues to increase. It's projected to reach just under 9 billion by 2025. And although not all of these phones are smartphones, many are, about 5.5 billion, and smartphone access is also increasing globally across many pockets of the world, but it's projected to reach about 7.4 billion by 2025. And as we know, smartphones have extraordinary computational capacity and allow for a very rich resource delivery. And pretty much any population you can think of, even some of the most traditionally underserved and vulnerable populations, either have access or are expected to get access to mobile technology. So I'm going to start off by talking about digital therapeutics, which is one component of this broader space of digital health. So again, digital technology has transformed our world, how we do finance and retail, and how we have social interactions, and how we have educational opportunities, how we have conferences these days. And so the space we're working in is really how can we harness the widespread availability and the growing ubiquity of digital technology to transform how we understand health and deliver healthcare. And so digital therapeutics is a term that refers to clinical grade software that is effective in preventing, treatment, or managing a disease or disorder. So it is actually a medical intervention. It's not a wellness app or a general health promotion app. It's actually taking the active therapeutic processes of a medical intervention and embodying that in the content and functionality of software. And so the software is delivering this medical treatment that, again, it is seeking to prevent, treat, or manage a disease or disorder. So for some examples, and I'll show you a lot more data later, but this could include, for example, something like delivering cognitive behavioral therapy on a digital platform. So helping people to learn how to identify and disrupt maladaptive cognitions and behavioral patterns, and provide them skills training and tools literally in their pocket on a mobile device that can help them manage self-defeating patterns of behavior and engage in more health behavior. It could include digital treatments for promoting medical regimen adherence for lots of different populations. So it's literally packaging an entire model of evidence-based care into a seamless digital delivery platform. So why is this useful? Well, first of all, it can extend the reach and the impact of clinicians. So we can offer clinicians additional tools in their toolboxes that they can offer to patients that can provide effective therapeutic resources to their patients 24/7, even when they're not with clinicians. It's kind of like supercharging the clinician workforce and expanding the reach and the impact that we can have with different patient populations. It's kind of like a clinician in your pocket. And we have seen now in many types of health behavior and health domains that these digital therapeutics, if they're developed well and really deliver state of the science treatments, can markedly improve patient outcomes when they're part of models of care. Another important dimension is that they deliver treatment with fidelity to best practices. So we know there's a lot of variability in what happens in various clinical settings, and we can ensure that these digital treatments are delivering state-of-the-science treatments with fidelity to any individual, anytime and anywhere. And again, access is expected to be very broad. Again, not every single population has access at this moment, but all of the projections are showing that that's expected to continue to change, and access is expected to increase globally. So the idea here is this can be scalable. This can promote widespread access to science-based behavioral health care. And we surely have seen that the demand for remote models of care is more, significant and has grown so much in the global pandemic crisis. So it's very timely. It's not only have we seen this growth in telehealth and telemedicine types of models of care, but we've seen a surge of activity in the space of digital health, including digital therapeutics, not only in what's happening in research, but what's happening clinically, what's happening in the funding sector, and dramatic growth in the tech industry and even in big pharmaceutical companies moving into this space. So it's very exciting because there's probably now a few decades of research that has shown that we can have a very robust and replicable impact on all kinds of health behavior, health costs, and health outcomes with these digital treatments. So this slide gives you a snapshot of this 2 decades of literature to give you sort of the big picture of what we've seen in research in this space. So we have seen when we're taking digital therapeutics and applying them to behavioral health that we can get high utility and acceptability to diverse audiences, lots of different patient and consumer populations. We can have a large impact on lots of health behavior and health outcomes. We have now seen in multiple studies that digital therapeutics can produce clinical outcomes in patients that are sometimes comparable or sometimes better than what patients experience with clinician-delivered care. And some people bristle at that and think we're trying to replace clinicians with digital treatments, but it's really helpful to know that there are active ingredients in these digital treatments that really can exert effects and really improve patients' outcomes and patients' lives. And surely in the space of behavioral health, which includes the areas of addiction and mental health disorders, we know that our behavioral health workforce really isn't sufficient globally to meet population level needs. So this is a way to know that we can have therapeutic resources that really can scale and expand the impact of our behavioral health workforce. And surely that has been underscored in the last year and a half when we've seen global increases in substance use and mental health challenges. We also know that these tools have been shown to increase the quality, reach, and personalization of care. They can be very cost effective in many different settings, and they don't always have to work the same way. It doesn't have to always be 12 sessions of this intervention or 8 sessions of that. They can be adaptive and change over time and be responsive to people's changing needs and clinical trajectories over time. So I'm going to give you a snapshot of one intervention just to start that is sort of an exemplar of a digital treatment that's been extensively studied. And this happens to be one that Warren and I and another colleague developed many years ago in a research iteration called the Therapeutic Education System. It's a digital treatment for substance use disorders, and it's been studied in NIH-funded clinical trials for a very long period of time and has a lot of evidence behind it. But I'm just going to give you a sense of what it is, and then show you when you implement it in different ways, the kinds of outcomes you can get clinically when it's part of care models. So briefly, this is an interactive, it was initially a web-based behavioral treatment and now is it's delivered on mobile platforms, but it's an intensive behavioral treatment for substance use disorders. It's based on a very strongly empirically supported behavioral treatment called the community reinforcement approach to substance use disorder treatment. So I'm not going to go into a lot of detail about this, but this is a gold standard treatment for substance use disorders. It helps people understand and disrupt harmful behaviors and cognitions that lead to self-defeating patterns of drug use. It's a very intensive intervention. It has 60-some components to it to really help people change their lifestyle and change their behavioral repertoire, and to leverage personal and social and vocational resources in doing so. And then it also sometimes, but not always, is accompanied by what's called a contingency management intervention, or an intervention where people can earn incentives contingent on evidence of certain sort of desired behaviors, like going to therapy sessions or providing urine samples that are negative for problematic substances. So they can get rewards contingent on those types of behaviors. And so that entire system, that whole reinforcement system, is automated within the context of this digital platform. So again, it's an intensive program. These are just some screenshots from the program, but it has a lot of tools, not just skills training components, but tools that people can apply in their daily lives at the moment that it might be most useful to them. So I'm going to show you a few studies that have examined this to give you a flavor for the kinds of clinical outcomes we see. And I have to start with a study, the very first one that Warren and I and some colleagues led long time ago, 2008. And this was a study with adults entering outpatient treatment for opioid use disorder. We know that opioid use is a significant issue in our country and continues to be for many years now. It's actually still the leading cause of death of Americans under age 50 in the US. And that's the population we recruited here, people who met criteria for an opioid use disorder. And in this particular trial, just briefly, every single participant in this study received medication treatment for their opioid use disorder, generic term is buprenorphine medication to help stabilize brain neurochemistry for folks with an opioid use disorder. But what we randomized on here was the type of behavioral treatment that they received along with the medication. So if you went into the condition that's reflected here in the blue column, you met with a therapist 3 times a week in individual therapy sessions where that therapist was trained to deliver with fidelity this gold standard community reinforcement behavioral therapy intervention to patients. If you went into the condition that was reflected in the red bar here, you had a therapist, you checked in with them every other week, but the bulk of your behavioral treatment was delivered through this digital therapeutic. In this particular case, it was done on site where people actually went to a computer lab at the healthcare setting, and they interacted individually with this digital version of this gold standard behavioral treatment. And then if you went into what's reflected in the gray condition, you received standard counseling, which was reflective of the kind of counseling that was offered in most outpatient treatment settings for opioid use disorder in the US at the time of the study. And so what you see, and again, this is just a snapshot of many, many types of data we got in this study, but you see that if you offload this behavioral therapy to a digital platform, that you can get outcomes, clinical outcomes that are as good as outcomes from exclusively clinician delivered care, both of which produce significantly better outcomes than standard treatment. And this was on a measure of objective assessment of your analysis data that looked at opioids and cocaine for this sample that had problems with opioids and cocaine. So just give you a couple more examples just to show you when you implement in different ways the kinds of outcomes you can get. This was a study conducted in methadone treatment. So this is a treatment setting. And these are folks coming in with opioid use disorder who all receive access to methadone medication, which is taken daily. And if you went into the bar that's reflected in yellow here, you had that medication and then you had access to the kind of counseling offered in the methadone treatment setting. If you went into the condition reflected in blue here, you had methadone medication offered daily, but you went into condition where your clinician-patient contact time was cut in half, and the other half was replaced with the digital therapeutic. So you might meet with your counselor for 30 minutes, and then you'd spend the other 30 minutes on using the digital therapeutic versus meeting with your counselor for 60 minutes. And basically what we saw is when you cut in half counselor-patient contact time and replace half of that with access to this digital version of this gold standard treatment, you have markedly greater opioid abstinence in that sample compared to the sample that received standard treatment. So we actually had the opportunity to study people's outcomes for 1 year in this treatment setting. And this differential that you see here that shows the advantage if you get the digital treatment as part of care persisted for that entire 12-month window. So, we're delivering with fidelity in an interactive way to the individual, ensuring that they're learning and acquiring the skills that are really essential to this behavioral therapy approach. And I think that's what's driving this effect that we see, is that we're really helping people learn effective skills to help them change and maintain changes in their drug-taking behavior. And then one more example I'll give you with this digital treatment, and this is a different design altogether. This is a design where we didn't touch the underlying model of treatment. We just said, what if we offer people the opportunity to get access to this digital treatment as a supplement to their existing model of care? It's just an adjunct to what the treatment setting is providing. And so here we see, again, this is a sample of patients with opioid use disorder, all receiving medication, again, either going into standard outpatient treatment or a model where they received access to a digital version of this intervention along with standard treatment. We see when we give them this software on top of standard treatment, we were able to retain many more of those participants than those who just received standard treatment. It's a pretty robust effect, and we've seen this kind of pattern replicated now in multiple studies. And this is looking at treatment retention in the first 3 months of their treatment episodes. So they come into treatment and we looked at how many were retained for the first 3 months. And we know that retaining people in treatment is a really important predictor of lots of other very positive clinical outcomes. The same pattern was visible when we looked at their drug use behavior, again, measured objectively by looking at urine toxicology data. We see that we had more evidence of opioid abstinent urine samples if you got the mobile tool as part of care versus if you did not. So this is just a snapshot of what we've seen in this space. There's a lot more we could share, but one thing that you should know that has really been transformative is that now in the US, digital therapeutics can be prescribed. So there's a new category of medical devices under the FDA's regulatory authority called prescription digital therapeutics. And you can submit data from rigorous clinical trials research to the FDA to review for safety and effectiveness, not unlike they would look at clinical trials data for a novel compound they might be considering for FDA approval. And then if you meet there are many criteria you have to meet, but if you meet the criteria and get sort of the FDA's blessing as a prescription digital therapeutic, this software can then be prescribed by physicians. And so the very first FDA authorized prescription digital therapeutic in this country was actually based on this digital treatment I just described to you for substance use disorders. The first indication in 2017 was specifically actually very broadly for substance use disorder treatment. And then there was a separate authorization in 2018 specifically for the treatment of opioid use disorder. So there's a label seeking, that this was an effective treatment specifically in the treatment of opioid use disorder. And I mention this here because this is exploding. It has actually grown tremendously in the last year to year and a half. In fact, the FDA has somewhat lessened their criteria to get this designation during the period of COVID, particularly for mental health related interventions to increase their availability during the pandemic. And there's just been tremendous growth. The FDA is actually getting flooded with data from companies seeking to get this status. So this is undoubtedly a key part of the healthcare of the future. And if you're a clinician and you're thinking about models of care, I think you will see this only growing in the marketplace and in terms of what is offered in clinical settings that you can actually prescribe software now. And so to do that, it has to be considered a medical device. It has to be software driven, evidence-based, and it has to make a claim. You have to seek a claim, a label to say this is indeed, we have data to show this is indeed effective in preventing, managing, or treating a medical disease or disorder. So it excludes wellness apps from the regulatory oversight. And I think what's exciting here, we have had for many, many years, clinicians come to us and say, we're really excited about digital therapeutics. What should I prescribe to my patients? I'm a primary care provider. I want to prescribe apps to my patients. What should I prescribe? And so, if you look at the App Store, there are such enormous amount of apps out there. How do you navigate the space and know what's effective and what's not? There are 200 wellness apps being created every single day. How do you navigate the space? And so this has been very helpful because you know that if something has gotten this designation from FDA, that it's gone through a very rigorous evaluation process, and that can help you have confidence that this really has strong empirical support behind it. So I just mentioned what we've seen in the space of substance use disorders, but we and others have had the opportunity to work in the space for many years now. And the kinds of patterns of effects on clinical outcomes that I just showed to you, we've seen across a whole spectrum of behavioral health and health behavior. So lots of tools affecting mental health, including clinical depression, including eating disorders, including anxiety treatments, including treatments for people diagnosed with severe mental illness, smoking cessation interventions, other substance use interventions for lots of populations. Also, we've seen a lot of utility with these interventions to promote medical regimen adherence, including medication taking among many chronic disease populations. So we've seen that this is a very robust effect that seems to be transdiagnostic and generalizable across many health domains. So I think there's an extraordinary opportunity. We know that there's very compelling data that these therapeutics can be effective and accessible for many health domains. We've seen they're increasingly available. So there are prescription benefit managers, very large ones, including global companies that are now creating digital health formularies to make certain digital therapeutics available to their clients. Their employers offering this to their employees. There is the prescription model that I mentioned in the US. And there's a lot of dialogue in seeking that's progressing rapidly now, seeking Medicaid and Medicare reimbursement for these interventions. So it seems like a really timely opportunity, particularly in the world of the pandemic, particularly as we have increased demand for behavioral health tools and remote models of care, to really scale up the access and of these types of therapeutic tools in many populations and contexts. And so what I'd like to do now is just to give you an example of how that could be done by briefly telling you about a project that we are doing in Latin America. So we've started in the country of Colombia, and the plan is to expand some of these activities with partners in Chile and Peru. This is funded by the US National Institute of Mental Health. So just briefly, Colombia is a country, as you likely know, that has generations of conflict, armed conflict. And we did have the FARC peace agreement about 5 years ago or so, but virtually every community across the nation has been touched by the conflict. And there are very high rates of mental health problems, particularly high rates of depression and high rates of very heavy alcohol consumption, often accompanied by domestic violence. And yet the mental health workforce to try to address this very large population level need is very small, and it's often confined to urban settings like Bogota, for example. So this is an example of a setting where you have high need but limited resources. And so how do you meet the population level need at scale? And so this is where we try to use digital technology to sort of supercharge the workforce, to try to expand the impact of the workforce. And again, this is in the country of Colombia, but you could imagine this is not dissimilar to certain rural communities where there's high need and limited resource capacity. And so that might be another example where you can really use digital approaches to scale access to resources. So this particular project is a broad partnership. It's not just our team at Dartmouth. We have wonderful research partners at Javeriana University, but we also work with lots of healthcare systems and governmental organizations, the Ministry of Health in the region, many national patient organizations, the payers in the region, and many non-governmental and multilateral organizations are part of this, including the World Health Organization and the Pan American Health Organization and the World Bank. And this is really key because this diverse array of stakeholders is really key to actually scaling this across the country and having an opportunity to sustain this. So the model briefly is where we work with primary care systems for the very first time, screening them in depression and problematic alcohol use. This is not, before this project, this was not addressed in any way in primary care in the country. And so there is some workforce training on what is depression, what is unhealthy alcohol use, but then the bulk of the intervention model is on a digital platform. So we have all the patient screening for these problems, and the diagnosis is entirely done through digital technology using validated clinical assessments. There's a digital clinical support, decision support tool that then providers can use. So when someone flags positive and meets criteria for one of these problems, they have right in front of them a tool that can help them walk through, for this patient in front of you, given their profile, here is what you could recommend, an array of options of best treatments for this individual. So it's helping to help guide them to deliver care in accordance with best practices. And then every single patient gets access to a science-based digital therapeutic platform that is specifically developed for depression and problematic alcohol use. So we screen in primary care settings. The colleagues, our partners, wanted to have this done by kiosks in the waiting room. So that's what happens. And then we screen for depression, we screen for alcohol use disorder, and then it goes down to clinical confirmation using the decision support tool. And so in this particular, it's a study, it's an implementation research study, but again, these systems, these primary care systems across the country are seeking to make this part of their clinical workflow. So here's some pictures. This is the interface that you see on the kiosks. And then this is this interface that the clinician sees for this patient in front of them. What's their PHQ score? What's their audit score? You get a lot of detail about this individual, and then it walks them through the process of confirming a diagnosis and offering treatment. And then this is a screen from the digital therapeutic that the patient can use that embodies lots of therapeutic tools that have been very effective in the treatment of depression and very effective in helping reduce harmful drinking. And it's provided to individuals on a digital platform that they can use anytime, anywhere, even when they're not in the primary care setting. So I just mentioned this as an example of a way you can think about new models of healthcare that centrally embed digital approaches. We started with a pilot study with 50 patients. We've now screened 17,000 patients in different urban and rural communities across Colombia. We continue this project. And so I'm not going to spend a lot of time to show you interim data, other than to say it's been extraordinary to see that these sites across the country who never screened for this, never talked about it, it wasn't part of what primary care thought was in their sort of clinical purview, are now routinely doing this with patients that come into their program and providing routine care in this setting for these behavioral health challenges. So our outcomes here are heavily looking at how does this impact organizational functioning, how does this impact clinical workflow, cost of providing care, but we're also looking at lots of patient outcomes as well. So I think I tried to highlight here that I think there's tremendous opportunity. The data are very compelling that you can use digital platforms to provide effective science-based treatments to lots of populations and lots of settings, and it can really scale access to effective resources. But also, digital technologies can help us better understand health behavior. So it can help us better assess in real time as people live their daily lives, what people are doing, what's their health status, what context are they existing within. And then with this rich data capture that can happen, let's say on a mobile device or by a wearable like a smartwatch, the goal is to provide personalized interventions and resources to individuals based on their needs and preferences, based on their clinical trajectory and clinical needs. And so there's a lot of exciting work. Some of it's very early stage still, but this is what I'm going to shift into now, is talking about the work where people are capturing information about people's health and behavior in real time and applying data analytic approaches, including dynamic computational models, to understand people's behavior over time with intensive longitudinal data capture, and to understand, for example, what confluence of factors might predict when someone might be at risk of something, when someone diagnosed with schizophrenia might be at risk of a psychotic episode, when someone with a substance use disorder might be at risk of a relapse event. And so this is a very busy area of research at this point, and lots of exciting work in this space of what's called sometimes digital health measurement. So first of all, some of the work in this space focuses on novel digital biomarkers. So the idea is there utility? Do we have any biomarkers that are captured on digital devices that might be really meaningful in understanding people's clinical status and its change over time? So the idea is, can we use digital tools and apply analytics to the data capture from these tools to measure individuals' behavior in vivo, and to really capture the granularity of behavior and the temporal granularity, and again, the factors that might impact behavior in the moment and within individual. And so the idea is that this might provide an opportunity, using these devices people carry around a lot of times anyway, like a mobile phone, to understand human behavior within their environmental and neurodevelopmental context. So I think there's even a tremendous opportunity to think about our theoretical models of human behavior and how we can have more contextually informed understanding of behavior, including health behavior, with this type of approach. So one methodology used in this space is called digital phenotyping. And digital phenotyping is a term that refers to the moment-by-moment quantification of individual level data collected on digital devices. So this could be where we prompt people to answer queries on a mobile device. We prompt them to answer very short questions about their mood, about their context, about their pain, about their craving, whatever the issue is, about their depressive symptoms, whatever the issue is, as a sort of snapshot in the moment. Sometimes that methodology is called ecological momentary assessment, or it could be by passive sensing, where there's no active response required by the individual, but rather you can capture all kinds of information about, their sleep and their behavioral patterns and their heart rate, their sociability, for example, with either the extraordinary sensing capacity on smartphones or by wearables like smartwatches. And there's even smart jewelry. There are many different ways that you can capture this information in an unobtrusive passive data collection methodology. And so, again, the hope is that this could help us understand factors that might predict clinically meaningful events for individuals, but also if indeed we can get really good predictive models, and we're not really there yet. We've got some really good but not perfect predictive models in this space. But if we can get really solid predictive models where we can actually predict with an individual sort of when, events of interest may happen, the idea is that this could also help us trigger right then and there a momentary intervention responsive to that. So delivering, people say, the right intervention at the right time. Some people call it just-in-time adaptive interventions. But that's the idea, is that the digital health assessment can trigger a responsive digital therapeutic intervention. So I'm going to give you a very high-level overview of what we've seen in the research in this space thus far. But in general, we've seen that there's a lot of promise. It's still early stage, but there's a lot of promise in the realm of looking at digital biomarkers for many health domains. So for example, and this has been very well replicated now, that smartphone sensing, when you measure, you extract features from sensors to infer people's activity or mobility or sleep, for example, it's very well linked to mental well-being and also even academic performance. There's also data that's showing that measuring sleep, things like sleep quantities, quality, sleep duration, is associated with various cardiovascular risk factors, waist circumference types of data, but also premature telomere attrition. And so some people are working in this space and feel like that digitally derived health risk data may provide real-time insights into biological aging. We've also seen, I would say a lot of this work is in the space of mental health. And one example here is that we've seen that when folks diagnosed with schizophrenia show anomalies in their behavioral patterns. So when you see evidence of an anomaly in their behavioral repertoire in terms of their mobility patterns and their social behavior, that has been shown to be predictive of an upcoming clinical relapse. In the space of substance use disorders, which is a space we work heavily in, there's a lot of interesting work as well. So, and it's also giving us some interesting insights into factors that sort of directly precede a drug use event. So here are a few examples. So among smokers trying to quit, lapses in smoking have been shown to be associated with increases in negative mood for many days and not just hours before a smoking lapse event. We get these clinical assessments when people come to treatment settings, let's say, these clinically validated assessments we capture in an episodic way that have a lot of clinical utility. But I think one of the exciting aspects of this type of data capture is that we might better understand sort of the relations among factors that might predict drug use events in new ways, like that, sort of this period of time of negative mood increasing before a drug use event seems to be a meaningful predictor. And we might not have captured that fully with some of our standardized assessments captured in an episodic way. We've also seen there's a really great group at the NIDA Intramural Research Center that's been doing a lot of pioneering work in this space, including helping us better understand the differential relationships between craving for drugs and stress and how those different dimensions predict drug use events, and really are showing different patterns of relationships with drug use events, including a study that showed that craving predicted imminent drug use, but self-reported stress has been shown to be much less predictive than craving. And then also this work is helping us understand different risk profiles for for use of different types of substances. So for example, another study showed that drug triggers, being exposed to things like drug cues or changes in mood that might be sort of risk factors for drug use among an individual, have been shown to increase for hours before cocaine use events, but we don't see the same pattern before heroin use events. So lots of opportunities to better glean insights into sort of the patterns of the factors and the interrelatedness among factors that might predict something like a drug use event and might inform intervention models. And then finally here, I wanted to speak briefly about the space of personalized interventions, where when you get this digital data capture, how can you provide a responsive intervention? So a couple of examples here, and this is a growing area right now, really exploding, I would say. So here are a few examples. So when someone is trying to quit smoking, and you're measuring in real time their smoking risk through digital assessment. When you provide tailored messages to them that are responsive to their level of risk, like in the moment advising them to chew a piece of nicotine gum, for example, when there's evidence of risk, we find that tailored messaging and that responsive messaging is more engaging and more effective than usual care. Similarly, when you measure things like people's nicotine withdrawal symptoms and their medication side effects in real time, that when you tailor your advice based on their status on those dimensions, we find more acceptability among smokers seeking to quit than traditional care. And then a project that we had the opportunity to do through a Science of Behavior Change initiative, we found that digital interventions that impact momentary self-regulation captured in the moment, things like your current state of emotion regulation, your current state of perseverance, that when we deliver an intervention that impacts that in the moment, we can impact health behavior, including next day health behavior across several populations. We've seen this in heavy smokers, and we've seen it with people meeting criteria for obesity with also diagnosis of binge eating disorder. So these are just some examples in this space. And we've just finished data collection and are analyzing data from a digital phenotyping study of patients with opioid use disorder. So what we're doing here is we're recruiting patients. It's actually in partnership with Kaiser Permanente. We're recruiting patients in outpatient medication treatment for opioid use disorder. And we are asking them to not only wear a smartwatch and carry a smartphone, but if they're willing to also share their social media data with us and to respond to questions we prompt them to respond to on mobile devices. And what we're trying to understand is, are any of these data useful in predicting meaningful events? So we know that, medication treatment for opioid use disorder is literally life-saving, but we know that some people don't take their meds as prescribed, or they drop out of treatment, or they relapse during treatment. And we know a lot about why that happens clinically, but the idea here is to see, can we get more granularity about events that might precipitate those clinically meaningful events? And so we're capturing all of this data and we're building predictive models to see, can any subset of this data predict dropout, or today I'm not going to take my medication, or today I'm going to use heroin. And we're also seeking to understand where there's redundancy in these data, where they don't contribute new information, or where they can complement, and where can we get sort of the strongest sort of signal that can help in these predictive models. And so just as an example, we're looking at all kinds of, we have all these sensors we're capturing, and activity levels and app usage and how often they log on and often on their screens, their heart rate, their sleep, their light exposure, their paralinguistic aspects of speech. They're not the text, not actually what they're saying, but there are all kinds of ways you can characterize speech that allow for inferences about mood, about sociability and other dimensions. And then we asked for smartwatch data heavily to get really good heart rate data. And then on the questions we asked them to fill out, we asked them about their sleep, their stress level, a number of aspects about pain, about their current craving in the moment, about their withdrawal in the moment, about are they in a risk context for using, about their mood, about their actual drug use behavior. And then we also had developed what's called a momentary self-regulation scale through this Science of Behavior Change initiative, where we developed and validated a measure that can, in the moment, capture different dimensions of self-regulatory capacity. So we asked them to fill out that very brief little measure on their phones, and also asked them about their medication taking. And then for those who are willing, and we found like 90% of the patients were willing for us to scrape their social media data. And so we're looking at not only their text communications and their postings, but we can get a lot of information about the topology of their social network and how that could change over time. And we, again, in a very exploratory way, seeking to understand, do any of these data help us get insights into people's clinical status or risk status? So this could be useful in a few ways. So NIDA, the funder of this, was interested in this heavily for the first bullet point here, which is, as we do clinical trials, we have various standard structured assessments we do. These are very useful in many ways, but is it useful to complement and extend the learning from those types of measures to also have data capture on digital devices that's captured literally as people live their daily lives when they're not in the clinic, but in a naturalistic context, to see if that kind of data might be useful to supplement outcome measurement in clinical trials. So that's one potential implication. And then the other, of course, is that if indeed we can really build these models well, as I mentioned earlier, it might inform when we trigger interventions for individuals, including individuals with opioid use disorder. So just to wrap up this section, the digital health measurement space really, I think, spans the spectrum from discovery science to translational science. So in the discovery science realm, it might help us identify useful digital biomarkers and also sort of outcomes measurement, like in clinical trials, but it also in the translational space might help us better understand personalized intervention deliveries that are responsive to the dynamic nature of behavior. And so if you look at the literature, I think right now we're kind of in a proof of concept stage. There's a lot of promise, lots of promise, and, sort of for different populations, but there is a lot of opportunity in this space. So if anyone is interested in this space, you could build your whole research career on this, because there's lots of opportunity to, really understand what are the important features to extract, what do we have validated measures in this space, to conduct rigorous trials that have control groups in this space, but also really importantly is reproducibility. We don't yet have a large literature that really shows that we can reproduce the kinds of patterns that are demonstrated in these sort of promising studies. So there is a lot of need in this literature for methodological rigor. But again, the proof of concept, I think, is compelling, as is the opportunity to apply this across lots of populations. So to wrap up sort of this part, and I'm mindful of time, I want to make sure we leave time for discussion. I think as we think of digital health, what I'm excited about, and it's heavily based on data and seeing lots and lots of data in this space, is that this can really be a generalizable solution, really, in addressing some of the systemic barriers we have to delivering science-based approaches to care, can transcend disease, can transcend behavior, population context, and really offer a scalable solution. And, really offering something that can be widespread, sort of accessible in terms of being widely implementable, but also we can develop these to really and take the sort of latest state of the science and be most effective and most potent and to do this globally. And as people talk about precision medicine approaches, both treatment approaches and even precision prevention approaches, there is a lot of opportunity to think about this as another type of data source that could be meaningful in the precision medicine space in providing personalized resources to individuals. So I just wanted to take a couple minutes to tell you about our center, because if you have any interest in this space, we have a lot of resources and expertise among our team that I just want to highlight. And our charge is to be a national resource. And we indeed, have a lot of international partnerships as well. And this is our website to our center. And we are really focused on using science to inform the development, evaluation, and implementation of effective digital health solutions, heavily in the digital therapeutic space, but also in sort of the full spectrum I described of digital health assessment. We're called the Center for Technology and Behavioral Health. We're housed at Dartmouth College in the state of New Hampshire in the medical school, but we have partners all over Dartmouth in the business school, engineering, policy shop, and others, but also partners all over the country and partners in several other countries. We have a strong partnership in Switzerland, in Latin America, and in Asia. And then it's very interdisciplinary. Lots of folks that specialize in behavioral health, addiction, mental health, but to really do this work and to sort of think about the whole translational pipeline of this work, we have folks that specialize in ubiquitous computing and emerging technologies and data analytics and health economics and digital health ethics and novel methodologies that could be useful in this work, implementation science and regulatory science to really think about scaling and factors that can impact that, as well as privacy and security and relevant policies. So it's a very interdisciplinary group, and we have the wonderful opportunity to work with lots of populations and lots of contexts, which has allowed for us to really understand how there might be utility for digital health in different settings with different populations. And I'm not going to go into this in much detail, but again, I highlight this as a resource for folks that might be interested. Our work is heavily structured around this stage model of intervention development. This was started by the National Institute on Drug Abuse and has been picked up by a number of NIH institutes as a framework. It's not a prescriptive model, but it's a framework that sort of guides development and testing of different interventions. And it's a sort of iterative model. And our work spans every one of these stages. So we have stage 0, which is really basic science research, where we might be developing a prototype of something. In fact, we just worked with NIDA to develop a prototype of a smartwatch to see if we can detect cocaine use events by smartwatch sensing. That was a very basic science. Stage 1 is where you might be looking at refining, early stage refinement of an intervention, looking at comprehensibility, acceptability, accessibility, sort of, lots of early stage questions, and then lots of different research designs, efficacy, tightly controlled efficacy trials, and more moving into real world trials, as well as implementation research, where we work in real world settings to really understand, and measure all the factors that might impact implementation and sustainability of a digital health innovation, including not just patient outcomes or clinician level data, but also in the administrator space, in the payer space, in the regulatory environment, what's really going to impact adoption to really have large scale population level impact. So this guides our work because we're really focused on, even at stage 0, when we're starting development of something, we're thinking about the potential implementability of that, even at that stage. So it's a recursive model. And in every single stage, we have a key focus on mechanisms. So as we understand, is this effective? We want to know why and how. We want to know the key mechanisms we have to target that can translate into clinical benefit. And so we've had a big focus in our research on mechanisms of action and seeking to understand mechanisms that can transcend population. So here's a snapshot of some of our current new research directions, including in our new iteration of our center. Grant includes a focus on transdiagnostic digital therapeutics, where we don't just have to focus on one disease or one disorder, but can embrace co-occurring conditions within the context of a single digital intervention. I mentioned the adaptive intervention work, these momentary interventions. We have a really, I think this is so important. We could spend a whole talk on this topic, really a large set of activities and experts that we've expanded to tackle the question of digital health ethics, which is hugely important. And we're seeking to have this of equal priority as we think about, sort of clinical outcomes, really thinking about ethical considerations in all of our work. We have some new partnerships with expansion of scholars from underrepresented minority communities, ranging from college student level to Ph.D., M.D., to early career scholars that will be part of digital health training and research in our group. We also have been working a lot on expanding research on providing these types of therapeutics in rural and also other low resource settings. So you might not have connectivity to the internet, right? And so you might not have a smartphone. Maybe you have, a phone that's not connected. So really, how do you give people rich therapeutic resources on a digital platform when you might not have reliable connectivity, for example, and really understanding how that impacts design and deployment. And then we also have a big partnership now with various scientific, clinical, industry, and governmental partnerships, including a whole multidisciplinary stakeholder advisory board to figure out how to better scale the science-based digital therapeutics globally. And understanding what's happening in the marketplace that can inform some of the meaningful scientific questions we could be asking, but also ensuring that there's high visibility of really what is producing the most potent effects from scientific research in getting those kinds of things out into the hands of people that can use them. So I will stop there. This is our contact info again. We have a very lively, active social media life. So if you'd like to follow us on Facebook or on Twitter, here's that information, along with, again, our website and my email address. And again, thank you so much for the opportunity to share this with you. And I am excited to hear your comments and questions. So I'll stop sharing and look forward to that. Thank you.
Thanks, Lisa. So some questions. So there's concerns in some neck of the woods about people excessively using their phones, their smartphones. Len Epstein did a really cool study where he took away people's smartphones and had them food deprived and asked them what would they rather have, their phones or food, and they chose the phones. How does that issue get addressed in this interesting space?
That's a great question. I left my phone once in a cab as I was hopping out at an airport, and I felt like I lost a limb or something. No, it's true. I mean, I think, people, it's an extension of, there's lots of resources, and it has a lot of utility to people for lots of reasons. And I agree with you. I mean, we clearly know, and it's, it's well documented that that there are a lot of potential harms and problems with excessive use, but yet also, as you've seen from some of the data I've shared here, there's also a lot of therapeutic value. I mean, I think that the device itself is just neutral platform, and there are all kinds of things that it can be used for, both positive and not positive. I agree with that, and I think that that's a really key consideration as we think about this. In fact, people are using digital therapeutics to help people with like gaming addictions, or like, smart, social media sort of challenges, so the platform is kind of neutral, but it can be used for deployment of different kinds of tools that and people's behavioral patterns. I think it's a very important consideration. I don't think there's enough research around that question, but I think we should think of the device as not sort of the problem, but how we use it and what's delivered on it, I think is something we have to be very thoughtful about.
Beautiful. So, one problem that we have here in the western part of Virginia is people being able to find access to resources. And I was wondering what role you think these technologies could be helpful in getting people plugged into services they might not be aware of. I was thinking like Yelp for services.
Yeah, I think it's a great idea. We know, for example, that, maybe 11% roughly now is the estimate of people that have a substance use disorder actually go to services. So there's a huge unmet need and opportunity for all these other folks who are struggling with substance use issues, not accessing services. And we know there are a lot of reasons why that's the case, including stigma, but accessibility is a big one. And so, I think there's an opportunity to think about this as sort of a conduit to treatment entry, or to raising visibility of options of treatment. One study we just completed. So I think there's a lot of opportunity in the space of using digital approaches, including, online sort of recruitment methodologies to reach hard to reach populations and give them resources, like you're saying, that might not be accessible to them. So one study we just finished that NIDA funded through the Clinical Trials Network platform was a study where we recruited really hard to reach, high risk for HIV, men who have sex with men, who are in like certain communities, like in Mississippi or Louisiana, or there are many, there are about 10 pockets of the country where we targeted people that have higher HIV prevalence, but very low density of resources for testing and even for PrEP access for people who test negative for HIV. So the entire approach was to test what are the most effective ways to reach these people online in very targeted messaging, link them to at-home HIV testing that can be done privately in their home, and then link people to PrEP for those who want it, who test negative, and then those who test positive going into to have a linking to treatment. And a lot of people now are really working out the methods around how to best recruit people. We looked at a bunch of different methods on that study. We've been able in other studies to recruit. Reddit, we found, for example, is a very effective platform for recruiting people with opioid use disorders. And some of our faculty have really figured out some good methods around that if folks have interest in that. But I think it's a very good point. I didn't speak about it much, but just thinking about digital approaches, going to sort of where people live in the digital space, and really understanding, how can we reach and raise visibility of resources in new ways, I think is a tremendous opportunity. And to your specific example, there is a group that NIDA's funded called Open Beds that has a platform that you can go to. It's now a clinician facing, but it's becoming consumer facing. So if you want to know, in your community that takes your insurance, who has a slot available today and what kind of resources they have for treatment for substance use disorders, you can go into this centralized platform, which is becoming a national platform, and learn about that. So there are some examples of some innovation in this space, but I think there's a lot of opportunity still.
Beautiful. Pearl Chu says, thank you for your very interesting talk. Could you comment on the acceptability of digital therapeutics and monitoring in the US and how that might affect this work? In the context of the COVID-19, it became apparent that digital monitoring is more of a norm in some parts of the world and perhaps not so acceptable in the US.
Yeah, it's a great question, and it's a big question. And I think that, this goes back to the issue of ethics. And so I think sometimes people, so let me say a few things. Sometimes people who work in this space of like privacy, for example, there's a dialogue around sort of protect private information, but there's also in many populations an interest in letting data flow in a way consistent with my preferences, letting data flow in a way that I want it to flow. So it's not just lock it all down, but rather thinking about models of data flow and data sharing. And I think in the health space, there's a lot to consider around this, but we have been seeing even, nationally now, there are a lot of monitoring platforms in many states that are looking at, sort of community level data that might predict when someone might be at risk of a big surge in overdose events, for example, with some of these monitoring and analytic methodologies, and for other types of phenomena as well. And so I think this is why I think we need to have a really active dialogue, a set of guiding principles and that really help us in this space understand what our best practices. There is a group called, Pearl, if you're interested in this, there's a group called Recode Health, RECODE, that is really doing excellent, I think, pioneering work in this space. But I think, the technologies are advancing and the sophistication in the analytics space is advancing faster than, how we're tackling all these parallel considerations that we should be addressing around monitoring acceptability, how to do it well, how to do it in a way that isn't overly intrusive. And yes, the COVID crisis has definitely accelerated this a lot. So I just want to underscore the significance of your question and that we don't have all the answers yet, but this is an area of growing activity. And so feel free to follow up if you'd like, but I encourage you to check out the Recode Health website.
Beautiful. We are out of time. Lisa, thank you so much for taking the time to share your research and what your center is doing. It's very exciting work, and we look forward to following it.
Thank you. Thank you so much for inviting me. It was a pleasure.
Have a nice day.
Okay.